Okay. Here are my disclosures, but they will not affect what I'm going to say in the next 20 minutes. The topic is timing of renal replacement therapy, but I put it to you that you will have to be clear in your mind what you want to achieve with renal replacement therapy before you can decide whether to start or not. And just as a reminder, CRRT or intermittent renal replacement therapy, both modalities have become essential technologies to help us looking after critically ill patients. RRT in particular helps us caring for critically ill patients. It allows us to remove toxins, excess fluid, and even allows us to prevent fluid overload. And obviously, by removing uremic and metabolic toxins, it provides metabolic homeostasis and removes not only endogenous waste products, but also drugs and other toxins. In the intensive care unit, RRT is also considered when we are thinking of helping other organs. We know that acute kidney injury has effects on other non-renal organs, and we may think about starting RRT to prevent organ failure of non-renal organs. Hopefully, RRT is just an temporary measure until the kidneys recover and have sufficient function to cope with the demand. So RRT, modern RRT in the acute critical care setting is a temporary support to help the kidneys coping during a period when the fluid and metabolic demands exceed endogenous function. And if you keep that in mind, and keep in mind what you're trying to achieve, then I think it may be a little bit easier to think to consider whether renal replacement therapy should be started. With regards to timing, if you think of starting RRT, then clearly you have all the advantages which I've just listed. But they come at a price, because RRT is well known to have adverse effects and complications. And they start from the time you insert the line to the time you provide renal replacement therapy, where you may have complications from anticoagulation, you may have complications from unrecognized losses of nutrients, unrecognized losses of drugs, to the overall implications. And that means more work, an increased workload for the nurses and increased healthcare costs. And it is also possible, as suggested by animal models, that RRT and some of these adverse effects delay the time to spontaneous recovery. So the question now is, when is the right time to start? When do the benefits outweigh any potential complications? If you go to the literature, then you'll find numerous studies, and a lot of studies focusing on the question, is early better than late initiation of renal replacement therapy? In fact, you'll now find 8 randomized controlled trials and more than 20 observational studies. The problem with these studies is that it's very difficult to compare them because they've used different criteria to define early and late. And at the moment, there isn't a single study, or there aren't two studies which have used the same criteria. They all use different cutoffs for either urea or creatinine. They use AKI stages, either 1 or 2 or 3, or they sometimes use time from admission to the intensive care unit to define early versus late. Just as an example, here are the 3 randomized controlled trials, and I want to draw your attention to the 2 columns on the right, where they give you the criteria for early and late. And just to illustrate the fact that investigators use different criteria and ultimately came up with different results. So in blue, you have positive studies. In white, you have negative studies. The same here. These are the next 3 older randomized controlled trials. Again, all trials using different criteria, having different results. But in the last 6 months, there's been a lot of talk and discussion again about the whole topic, because 2 randomized trials got published almost within 1 month. And to date, I would put it to you, they are most relevant to current clinical practice. This is the acute study, which was conducted in France in 31 intensive care units. And patients were randomized to early versus late renal replacement therapy. As an inclusion criteria, patients had to have acute kidney injury stage 3. So that meant a tripling in creatinine from baseline. In addition, they needed to have evidence of other organ dysfunction, either be on the ventilator or be on vasopressors. So patients with acute kidney injury stage 3 plus evidence of other organ dysfunction were randomized to either early or late renal replacement therapy. Early meant they started renal replacement therapy within 6 hours, and late or delayed renal replacement therapy meant they would stay off renal replacement therapy unless they had an emergency indication or an urgent indication as listed here. So unless they were very oligoanuric for at least 3 days, or had hyperkalemia or severe acidosis, or refractory pulmonary edema. So our classic absolute indications for renal replacement therapy. And as you may know from this publication, when they looked at 60-day mortality, there was absolutely no difference between the two groups. So patients who were treated with early renal replacement therapy did not have a survival advantage. And the authors went further and looked at the proportion of patients in whom renal replacement therapy could be prevented or avoided. And clearly, it couldn't be avoided in the early group because that's how this was their criteria, their inclusion criteria. So if they were randomized to early renal replacement therapy, then patients got renal replacement therapy. So there was no delay, and there were no patients without renal replacement therapy. But in the delayed group, as you can see here, almost 50% of patients never needed renal replacement therapy because they never met these criteria. So you could say it's actually a positive study which shows you can wait if you want. If you've got acute kidney injury stage 3, you can indeed wait, and the advantage is that you may save patients and prevent renal replacement therapy. But again, this comes at a price. If you do that, then as you can see here, there's the mortality difference. And I'll take you through these numbers. So patients treated with early renal replacement therapy had a mortality of 48%. Patients randomized to late renal replacement therapy who didn't need it had a much lower mortality. So it was good. It could be prevented, and the adverse effects of renal replacement therapy were avoided. But if they then needed renal replacement therapy later because they had absolute indications, then their mortality was significantly higher. And so the problem with these results is that it's very difficult to translate them into clinical practice, because at the time when we see somebody with acute kidney injury stage 3, we do not know what's going to happen in the next 72 hours. We do not know whether the person will recover and can be spared from renal replacement therapy, or whether they're going to deteriorate and they need it as an emergency, and in which case the mortality is significantly higher. This is the first study, which obviously has generated a lot of discussion amongst clinicians and experts in the field. The second study, published at the same time, is a single-center study from Germany, where they also try to address the question, is early renal replacement therapy better than late renal replacement therapy? The study was conducted in a single center. It's a mainly predominant surgical intensive care unit with a large proportion of cardiac surgical patients. And in this study, early renal replacement therapy was defined by earlier criteria. So to get into the study, patients needed to have acute kidney injury stage 2. Just remember, it was stage 3 in the Akiki study. In addition, they needed to have a positive biomarker, and they needed to have one other criteria, one of the factors listed here. So some evidence of some organ problems or a marker of being quite sick. Patients who met these criteria were then randomized to either starting renal replacement therapy within 8 hours or waiting until they met acute kidney injury stage 3 or had signs of absolute indications. And in this study, using these criteria which I've listed, there was a significant difference in 90-day mortality. Patients who were commenced on renal replacement therapy earlier had a significantly better survival, a significantly lower 90-day mortality. So what do you make of these two studies? They were conducted in different patient populations in different countries. They used different criteria to define early versus late. Given the uncertainty and also the fact that it still leaves us with a lot of questions, Professor Ronco and his colleagues conducted an ADCI meeting last year to address some of the questions, and they put the whole meeting, the whole ADCI meeting, under the umbrella of precision medicine personalized CRRT. And as part of this meeting, one working group, which was chaired by Professor Kellum, looked at the question, what is the ideal timing? What is the ideal time to start renal replacement therapy, given the data we've got at the moment? And the group reviewed the whole clinical practice of CRRT in light of all the existing data. And first of all, it became clear that there are so many factors which make us decide to start renal replacement therapy at the bedside. There's for sure severity of acute kidney injury. And we look at our traditional markers to indicate how severely injured or how severe acute kidney injury is, and whether there are complications of acute kidney injury, including fluid overload or uremia. In addition, we put this into the whole context and look at the patient and try to understand how acute kidney injury affects the rest of the body or the other organs, and their degree of survival and chances of recovering, leaving the intensive care unit alive. We'll also look at trajectories and see how things are progressing. So an indication that things are getting worse may prompt us to start renal replacement therapy earlier. All of this obviously has to be done with consideration of the potential risks, which I talked about earlier. A study in the literature, one of the dosing studies, showed that 50% of patients who had renal replacement therapy had at least one adverse event, one adverse complication. So it doesn't come without any costs. And finally, in individual patients, there may be other reasons which make us decide against or in favor of renal replacement therapies. There's certainly the technologies, we need the staff to do it, we need to make sure that we have the right expertise, and we have to consider the patients and the patients' relatives' wishes. So a lot of factors which come into the decision whether to start or not. They come in addition to the simple criteria which were used in these randomized controlled trials. And with that in mind, we essentially established a few conceptual models. For a start, kidneys have a limited capacity. In some patients, some of us will have normal kidney function, but it is limited. And some of us, kidney function may even be impaired as a result of chronic kidney disease. During periods of acute illness or critical illness, there are extra burdens and extra demands put on the body and the kidneys, because suddenly the kidneys, with their limited capacity, have to cope with the extra metabolic demand and the extra fluid demand. And this varies in individual patients. And we, as a conceptual model, felt that the renal replacement therapy should be considered when there's a discrepancy between what's being asked of the kidneys, so the metabolic and fluid component, and the kidney's ability to cope with that. And this differs between individual patients. And just as an example, we thought to illustrate this, it would be easier to have it as a figure. So if you imagine your kidneys, you either have normal function or you may have impaired kidney function, or you may have very poor kidney function. During critical illness, there is some degree of demand put on the kidneys, and that's either the solutes or that's the excess fluid. And if your kidneys can cope with that and everything is even balanced, then it doesn't quite matter how bad the fluid overload or the solute load is. As long as the kidneys can cope with it, that's fine. That's your imbalance. But if there is an imbalance, then that's the time to think about renal replacement therapy. And you can put it in a different format, in some sort of algorithm, as we've done here, where you've got, essentially, you're faced with somebody who's got acute kidney injury. If there are no immediate indications to start renal replacement therapy, no life-threatening complications, then you may wait and see whether you can optimize the situation, and you can consider waiting and reassessing the hemodynamic and metabolic situation. During this time, you could do everything possible to help kidneys recovering and help reducing the burden. Clearly, a regular assessment of the situation is essential, with a review of the trajectory and the progress. And if at any time there are clear signs that things are deteriorating in the form of either progressive fluid overload, progressive acidosis, progressive non-renal dysfunction, so signs to tell you or tell us at the bedside that the burden placed on the kidneys is getting too much and the kidneys are struggling and not coping, that may be the time to think about renal replacement therapy. Clearly, if it doesn't happen, then you may be safe to continue waiting and continuously reassessing the situation. So that's where we are in terms of precision medicine at the moment. It still comes down to clinical assessment and using the skills we've got. Obviously, all this relies on a regular review, regular reassessment. The question is, what's in the future? Is there anything we can do better? Is there hope to improve the situation? And with that in mind, I'd just like to take you back to the acute study and show you the mortality figures once more. So, as I've already said, the problem is that when faced with somebody who's got acute kidney injury stage 2 or stage 3, we have at present no tool to tell us what's going to happen in 60 hours, in 72 hours. We do not have any tools to tell us whether the kidneys are going to recover or not. Clearly, if we knew they're going to recover, then it would be advisable to avoid renal replacement therapy, given that the acute study showed in the group of patients in whom renal replacement therapy could be avoided, they had a significantly lower mortality. If we know that the kidneys are not going to recover, then that's the time to start renal replacement therapy, because if we wait too long, then we're faced with a situation similar to the delayed group who subsequently needed renal replacement therapy and had the highest mortality. So what we really need is something which tells us, gives us indications and information about the trajectory. And at the moment, we don't have them. And that's what we need. It may be novel biomarkers. It may be tests, imaging tests. It may be that we just have to learn how to interpret the current tests. But at present, these tools are missing. If we had them, then we could do precision medicine and provide personalized renal replacement therapy. So in conclusion, renal replacement therapy should be considered when the metabolic and fluid demands exceed the capacity of the kidneys. And this time point varies and is different for each individual patient. To provide individualized treatment, we need to look at the whole patient, the clinical context, the trajectories, and the degree of non-renal dysfunction, non-renal organ dysfunction. But what is needed is better diagnostic tools to help us deciding when to start renal replacement therapy in a timely manner and when to avoid it and avoid the complications. Thank you very much.